so they can't hear and see me. So a few housekeeping notes. As you all know, you're muted. So if you have any questions concerning this presentation, if you can please send those questions to my email, adrenia.tolliver@vdh.virginia.gov, and we'll try to get those answered by our presenter. If not tonight, I will get those to him, and we will make sure we get an answer to you because all of your lines are muted. Please make sure that you have registered in Train so I can go back in and verify you after tonight. If you're in a group at your local health district, make sure that you sign in with your coordinator, or use the email on the screen to email us your name for attendance purposes so we can verify that you did attend on tonight. All righty. So on tonight, we're going to talk about hepatitis A in Virginia, behind the scenes of Epi outbreak. And we have one facilitator on tonight, and that's Jonathan Falk, who is the Epi program manager here at VDH from the Division of Surveillance and Investigation. So I will turn the presentation over to Jonathan.
Thank you, Adrenia. Good evening, everyone. So unfortunately, my partner in crime, Marshall Vogt, had a scheduling conflict arise and was unable to join our presentation, but we will make the most of it. Soldier on. So this evening we will be covering all things hepatitis A, the basic biology of the hepatitis A virus, its epidemiologic profile, the vaccine, how we conduct case and outbreak investigations, and updates on the multi-state outbreak of hepatitis A. So buckle up, baby birds, it's time to fly. The term hepatitis means inflammation of the liver. A number of viruses, including hepatitis A, B, and C, can cause inflammation of the liver. The viruses that cause hepatitis A, B, and C belong to three different families of viruses. The hepatitis A virus belongs to the family Picornaviridae and is a non-enveloped, positive sense, single-stranded RNA virus. And this is very different than hepatitis B and C. Hepatitis B is a DNA virus, part of the Orthohepataviridae family, and hepatitis C is an enveloped virus that is also positive sense and single-stranded RNA, but is part of the Flaviviridae family, which may sound familiar because the Zika virus is actually part of the same family of viruses that hepatitis C is. So fun fact, hepatitis C is more closely related to Zika virus than it is to hepatitis A or B. Hepatitis A virus is stable in the environment for months. It can survive low pH and freezing temperatures, but it can be inactivated at high temperatures of 185 degrees Fahrenheit or higher for 1 minute, or disinfected with a 1:100 dilution of bleach. The hepatitis A virus causes its infection by being swallowed, where it finds its way from the stomach to the liver. In the liver, it replicates, is excreted in biofluid, and then shed in the stool of infected persons. The hepatitis A virus is present in the blood of infected persons, and there can be bloodborne transmission of hepatitis A virus. However, it's rare, primarily because the concentration of virus in the blood is many magnitudes lower than the concentration of the virus in the stool. So this is primarily a fecal-oral transmission of the virus through the stool that then people consume or swallow, and then become infected. So the highest concentrations of viral shedding in the stool occur 2 to 3 weeks before to 1 week after the onset of illness. Most people stop being infectious 1 week after jaundice appears, but children and infants may excrete the virus longer than adults. And I think that's a key point here. Most people are most infectious before they actually have symptoms of the disease. So before they even know that they have a hepatitis A virus infection, they're actually already infectious and have been spreading it potentially to others for at least 2 weeks. And just as a side note, the hepatitis A virus, humans are the only natural reservoir for this virus, similar to smallpox and polio. One of the notable symptoms of hepatitis is jaundice, or the yellowing of the skin or whites of the eyes, as you can see depicted here in the picture on the slide. The earliest descriptions of epidemic jaundice are attributed to Hippocrates, and we also have documented reports of outbreaks of jaundice, which were likely caused by hepatitis A, dating back to the 17th and 18th centuries. Hepatitis A was formerly called infectious hepatitis, and prior to any sort of sophisticated lab testing, we were able to differentiate hepatitis A from hepatitis B in the 1940s just based on the incubation period of those infections. And I'll kind of explain that in another slide here in a little bit. But hepatitis A, the virus itself, was formally isolated and identified in 1979. Until 2004, it was the most frequently reported type of hepatitis in the United States. And generally speaking, prior to 2004, international travel was considered a minor source of hepatitis A because it was so endemic throughout our country. However, after 2004, international travel became a substantial source or proportion of reported hepatitis A cases in the U.S. and does continue to circulate throughout the world and is highly endemic in some areas, including Central and South America, Africa, the Middle East, Asia, and Western Pacific. The virus is typically acquired through the fecal-oral transmission route by direct person-to-person contact or by consumption of contaminated food or water, as you see in the picture. I will note that waterborne outbreaks are generally more infrequent than foodborne outbreaks, and waterborne outbreaks are typically associated with sewage contamination or inadequately treated water. The average incubation period, or the time from the exposure to the virus to the onset of symptoms, is approximately 28 days, but it can range anywhere from 15 to 50 days. Symptoms are clinically indistinguishable from other types of acute viral hepatitis, and I think that's an important note. Just at the face presentation to a medical provider, these symptoms for hepatitis A are indistinguishable with other forms of viral hepatitis. But hepatitis A is generally mild and self-limiting. In children younger than 6, the majority, almost 70% of those hepatitis A infections in children under 6 are asymptomatic, meaning the kids don't really show any sort of signs or symptoms to suggest that they are potentially ill with a hepatitis A infection, and yet they are still contagious. Symptoms will include fever, malaise or tiredness, anorexia, nausea, and abdominal discomfort, and then generally that is followed within a week by the presence of dark urine, pale stools, and jaundice. The case fatality rate overall for hepatitis A infections is approximately 0.3%, but can be a little bit higher for folks 40 and older, and that's looking to be around 2%. Fulminant hepatic failure, or acute liver failure, is the most common severe symptom occurring in approximately 1% of reported cases. And we typically see this acute liver failure among those with chronic liver disease, or at least those with chronic liver disease are at a higher risk of acute liver failure. The resulting severe impairment of the liver's function can require patients to need a liver transplant. And the mortality rate for fulminant hepatic failure or acute liver failure for hepatitis A infections can be as high as 80%. So while the severe outcomes are relatively rare, they're quite severe for those individuals. The clinical illness will resolve for most cases within 2 to 3 months, and generally within 6 months for nearly all cases. Unlike hepatitis B and C, the hepatitis A virus infection does not result in chronic infection or chronic liver disease. There is no specific medical treatment for hepatitis A infections, just supportive treatment and case management during active infection, and vaccination and immune globulin as preventative measures. Although risk factor data is often missing or not identified for reported hepatitis A cases, the data that we have collected to date would seem to suggest the following groups may be at an increased risk for hepatitis A virus infection. First and foremost, international travelers, especially travel to rural areas that are considered to be in high-risk countries, or those with close contacts to international adoptees from those high-risk countries. And I would recommend anyone who is traveling abroad to utilize the CDC's Travelers Health webpage. It's an excellent source for diseases and recommendations for the different areas that you might be traveling. Men who have sex with men, persons who use drugs, persons with specific occupational risks, those who have clotting factor disorder, and persons with chronic liver disease also are at an increased risk for hepatitis A virus infection or severe outcomes. Moving on to the hepatitis A vaccine. It first became available in 1995. The Advisory Committee on Immunization Practices, ACIP, recommended the administration of the hepatitis A virus to persons at increased risk for the disease that we just mentioned in the previous slide. And then routine vaccination for children began in certain states as early as 1999. And then by 2006, the ACIP nationally recommended routine hepatitis A vaccinations of children for the United States. And you can see on the graph there on the slide, the map of the country on the left is pre-vaccination era. So looking at 1987 to 1997, and you can see a lot of the endemicity of the virus in the United States was more on the western side. But post the vaccine rolling out, we very quickly had a drop in hepatitis A cases throughout the United States. There are 2 inactivated whole virus vaccines, one from GlaxoSmithKline or GSK, which is the HAV-RIX or Havrix, and the other from Merck, which is the VAQTA or the Vecta. There is also a combination hepatitis A and B vaccine available for those 18 and older called Twinrix, but I will primarily cover the pediatric series today. However, again, on the CDC website, they have resources and information on all 3 of these vaccines. This is a screenshot of the recommended children and adolescent immunization schedule for ages 18 years or younger for 2019, and you can see hepatitis A schedule highlighted in the bottom in red. It is recommended that children in the United States receive hepatitis A vaccine at 1 year, ages 12 to 23 months. However, children 2 to 18 can also be considered for vaccination. Both Havrix and Vecta are given as a 2-dose series, with the second dose given at a minimum of 6 months from the first dose. The hepatitis A vaccine provides long-term protection against hepatitis A infections, with studies showing persistence of antibodies for at least 20 years after administration of the vaccine. The vaccine is also highly immunogenic, with 95% of individuals showing protection against the virus after just 1 dose, and then nearly 100% after both doses. Those at increased risk for hepatitis A infection or severe outcomes that were mentioned above or before should receive the hepatitis A vaccine. The vaccine is also available to anyone who wants it and may also be considered based on local epidemiology for the following groups: healthcare workers, childcare workers, sewer workers or plumbers, and food handlers. If someone has had a severe allergic reaction, for example, anaphylaxis, to a vaccine component, or following a prior dose of the hepatitis A vaccine, they should not receive the vaccine. Persons with moderate or severe acute illness should be deferred from receiving the vaccine until their condition improves. Because the hepatitis A vaccines are inactivated, risk to immunocompromised persons or those that are pregnant is considered low, and the vaccination is recommended based on the risks associated with the vaccination versus the risks associated with the hepatitis A virus infection. More details can be found on the CDC's immunization schedule, and there is one specifically that speaks to recommendations for adults by medical condition and other indications. Most commonly, site pain, erythema, and swelling are the reactions that are reported in roughly 20 to 50% of recipients of the vaccine. The reactions are generally mild and self-limiting, and to date there have been no serious adverse reactions reported for either of the hepatitis A vaccines through the Vaccine Adverse Event Reporting System, or VAERS. So now I'm going to dive into our case investigations. Hepatitis A was made nationally notifiable in 1966 and is considered a rapidly notifiable condition in Virginia meaning that if hepatitis A is suspected or confirmed by a lab or provider, then it should be reported immediately to the local health department, preferably by phone. When a suspected case of hepatitis A is reported to the health department, we begin an investigation, and that will include confirming the case status of the individual, investigating the source of the exposure, documenting any risk factors, protecting close contacts, identifying high-risk situations, and providing education and recommendations to prevent additional cases. A standardized surveillance case definition is used when conducting hepatitis A investigations and in reporting case counts to the CDC. The case definition may use clinical, laboratory, and/or epidemiologic information to determine a confirmed, probable, or suspect classification. This process is different than the process of medically diagnosing a patient with hepatitis A infection. And we will occasionally get questions about that or run into some misunderstandings. For our purposes for public health surveillance, we use a surveillance case definition in order to be able to standardize our case count reporting between all 50 states and to the CDC in order to ensure that we can compare numbers adequately between all the states and at the national level. And this is very different than a medical provider trying to diagnose and treat and manage a patient. And so, there may be occasionally times where we say that we don't have enough information to call this a confirmed case of hepatitis A, but that does not necessarily mean that we are saying that this person does not have hepatitis A and that we would not step over the medical provider in their process of trying to treat and manage that patient. So with the hepatitis A, there is only the confirmed case classification, and in order to call someone a confirmed case of hepatitis A, we would need either a case that has a positive hepatitis A virus RNA test by nucleic acid amplification or PCR or genotyping, or we have a case with an acute illness, discrete onset of any sign or symptom consistent with viral hepatitis, as well as jaundice or elevated total bilirubin levels, or elevated serum alanine aminotransferase or ALT levels in the absence of a more likely diagnosis, and is positive for IgM anti-hepatitis A virus antibodies. So it's a serology test for that second criteria. I will note that for almost all patients with an acute hepatitis A infection, they will have detectable IgM anti-HAV beginning 5 to 10 days before symptom onset, and the serology test can be positive all the way through 6 months after the infection. We will occasionally get false positives for these serological tests, especially when they are performed for non-acute abnormal liver function tests. So generally when we are receiving our initial report, and it's a positive serological hepatitis A lab result, when we reach out to the provider or the hospital, one of the first questions we will ask is what was the reason for testing for hepatitis A, and if it was part of a routine test, just because they have some sort of chronic liver disease or they had something that the patient or the provider is managing, those tend to be more likely false positives rather than some sort of acute onset of symptoms that then resulted in the testing for that individual. The last one is, again, the same criteria that I mentioned before in terms of clinical criteria, but instead of the positive lab, they have contact with a lab-confirmed case of hepatitis A 15 to 50 days prior to symptom onset, meaning that we are able to epi-link them to a lab-confirmed case. In addition to classifying the reported case, we do make an attempt to interview the patient and identify the source of the exposure and potential risk factors. This allows us to better characterize the epidemiologic profile and detect possible changes in infected populations. For example, in 2016, we had a handful of hepatitis A cases reported to us, and between all of them, there was no recent international travel, which was unusual at the time compared to what we had known about hepatitis A infections in the U.S. And upon further investigation, along with laboratory testing, it was determined that there was a foodborne outbreak that was caused by contaminated strawberries that affected Virginia, resulting in over 100 cases over a 4-month period. And for those of you who may have been around or involved in MRC at that time, or just tied into public health, you may recall that this was the tropical smoothie outbreak in 2016 for Virginia. And as you can imagine, when we think back to the incubation period for hepatitis A, when we're reaching out to these persons and potentially doing, a food history and looking at close contacts and risk factors, we have to kind of ask, going back 2 weeks all the way up to 50 days or almost 2 months, and have them try to recall potentially people that were sexual contacts or household contacts, or, trying to figure out if they may have been in some other situation that may put them at risk of exposing other people. And so the recall bias and the challenge of trying to gather information over a long period of time is certainly a challenge with these case investigations. But that being said, we will try to identify potential high-risk situations beyond household and sexual contacts that may necessitate more public health response in order to prevent the spread of disease. And this could include a confirmed hepatitis A case in a healthcare worker, or employee or child at a daycare center, or in a food handler. And again, those are particularly noteworthy because of their potential to cause an outbreak and expose many other people to hepatitis A. Identified close contacts or others that may have been exposed to hepatitis A are typically recommended for post-exposure prophylaxis within 2 weeks of the last known exposure. Generally, PEP, or the post-exposure prophylaxis, is not recommended beyond 2 weeks because the efficacy of PEP administered after this period of time has not been established. If successful, the PEP will prevent the development of symptomatic illness or lessen the severity of the illness if it develops, and should help prevent future transmission. A close contact may receive either the hepatitis A vaccine or the hepatitis A immune globulin for PEP, depending on their age. The vaccine is generally recommended for PEP in healthy persons 12 months through 40 years of age, while immune globulin is preferred for persons older than 40 and children younger than 12 months, as well as for immunocompromised persons and those with chronic liver disease. Did you want to take a 5-minute break or just? Okay. We are going to keep on going. So, outbreak investigations. The Virginia Administrative Code, specifically 12 VAC 5-90-10, defines the term outbreak as the occurrence of more cases of a disease than expected. I would expand this a little bit further to say that it is the occurrence of more cases than expected associated by person, place, and time. In addition to individual reportable conditions, suspected outbreaks or clusters of disease are also reported or reportable to the health departments. Now, there are a few reasons for investigating these clusters or outbreaks, and hopefully to most folks on the call, it would make sense that the primary reason is to identify and eliminate the source of infection and control the spread of disease. But we may expend more energy and resources investigating these outbreaks or clusters to describe or learn more about the disease, to evaluate prevention strategies, to possibly train, exercise, or learn epidemiology or public health preparedness skills, or even to address the public's concern regarding a specific event. So on the screen, you have the textbook steps to an outbreak investigation from the CDC. I will be focusing primarily on VDH's activities in the field during an outbreak investigation related to hepatitis A, but for those interested, I have provided a link to CDC's online training lesson for investigating an outbreak, which is part of their Principles of Epidemiology and Public Health Practice. Many of the activities conducted during an outbreak investigation are very similar to the case investigations. However, there are additional response activities, coordination, and information sharing that goes on as well. For example, when we conduct case investigations as part of an outbreak, we may have additional questions that are specific for the event, and/or we may make additional concerted efforts to collect biological specimens or food samples or environmental samples that we may hypothesize to be involved in the outbreak. For surveillance activities, we may ramp up our active surveillance for case finding purposes. And just to kind of make a side note here, most of our disease reporting for public health relies on passive surveillance, which is where the medical providers in the community understand the regulations in the Code of Virginia and their responsibility to report to the local health department. And so we passively rely on them to contact us when there is a case that needs to be reported. When we have an outbreak situation or an emerging disease event like the vaping and lung injuries, we will normally also start active surveillance, which is where we reach out to those medical providers and encourage them to report or contact them to see if they have had anyone present that may match into this particular outbreak. We will also perform situational reporting and do some enhanced information sharing as we take a look at all of our cases that are coming in for that outbreak. Health information activities may include pushing out press releases or other tailored communication to no, that's fine. Other tailored communication to internal and external stakeholders. And prevention activities may include vaccinations or prophylaxis campaigns like we're doing with hepatitis A vaccines and points of dispensing in some health districts. Excuse me. We may also look at evaluating policies or infection control practices, as well as make additional recommendations to enhance prevention efforts. And there was a note that the steps that I have in the slide are hard to see, and I apologize for that. I can quickly just rattle them off, but I believe we'll be sharing these slides and the link as well following this presentation. But the steps that you see listed there, the first one is prepare for field work. The second one is establish the existence of an outbreak. The third is verify the diagnosis. 4, construct a working case definition. 5, find cases systematically and record information. 6, perform descriptive epidemiology. 7, develop hypotheses. 8, evaluate hypotheses epidemiologically. 9, as necessary, reconsider, refine, and reevaluate hypotheses. 10, compare and reconcile with laboratory and/or environmental studies. 11, implement control and prevention measures. 12, initiate and maintain surveillance. And 13, communicate findings. And I will note that the steps that you have listed there do not have to occur in that specific order. There can be multiple steps kind of in process during an investigation at the same time. For example, implementing control measures and prevention measures. We certainly would do that at the very beginning when we have a suspected outbreak reported, but we may refine those as we learn more about the actual causative organism and some of the risk factors associated with that particular outbreak. Okay, so we're going to kind of end the presentation going over the current multi-state outbreak, and I will note that a number of these slides came from Marshall as well, so I will do my best to kind of cover the material that he had on the slides as well. Nationally, CDC identified a multi-state outbreak of hepatitis A in 2016, so we're going back 3 years for this particular event. From August 1st, 2016 through December 13th, 2019, 30 states, including Virginia, have reported a total of 29,171 cases, 17,704 hospitalizations, and 298 deaths. So quite an impact on a number of states over the last 3 years related to hepatitis A. And I know for our state specifically, and we'll take a look at these numbers in a minute, I mean, we're kind of epidemiologically going back to pre-vaccination era numbers for some of these states. And for us, well, I'll talk about that in the next slide. CDC is providing ongoing epidemiologic laboratory and vaccine support to states experiencing outbreaks of hepatitis A. And nationally, they have identified the following groups that are considered high risk for acquiring a hepatitis A infection or developing serious complications. And these folks should be offered the vaccine to prevent and control the outbreak. They include people who use drugs, both injection and non-injection, people experiencing unstable housing or homelessness, men who have sex with men, people who are currently or were recently incarcerated, and people with chronic liver disease, including cirrhosis, hepatitis B, or hepatitis C. And so these groups are a little bit different than the groups I had mentioned earlier. This is primarily a person-to-person sort of event that has been rolling through the last 3 years, and not something that is just an increase in international travel associated cases coming into the U.S. And based on that, the identified risk factors that are on the screen are the primary ones that we are looking at as risks for transmitting the transmission of this virus person to person. Next slide. Virginia conducted a retrospective review of our hepatitis A cases reported since 2013. Based on this analysis, Virginia met the CDC definition of an outbreak state beginning January 1st, 2019. On April 23rd, VDH officially declared that they were an outbreak state that was part of this multi-state outbreak of hepatitis A. Of the 282 cases of hepatitis A reported in Virginia so far for 2019, 262, or 93% of them, have been associated with our statewide outbreak. Of the 262 cases, there have been 166 hospitalizations, accounting for 63% of those cases, and 0 deaths. And Virginia's outbreak does mirror the national trend, as well as those seen in other states. Next slide. I do have another slide here, and I apologize. It's kind of packed with numbers and percents, but it does summarize some of this. Kind of going a little bit deeper with our data, the majority of these cases, or 52% of them, have occurred in the Southwest region, which, if you look at the national map again, Kentucky, West Virginia, Tennessee was sort of a hot spot for these cases earlier this year and even into last year, and so that kind of matches with how we would expect person-to-person transmission to occur. However, over 20% of these cases have also been identified in the eastern region of the state. Approximately 54% of them are male, and the median age is 37, but ranges from 16 to 81 years. And it is interesting to note that our 63% hospitalization rate is a little bit higher than what we have historically seen as the hospitalization rate for reported hepatitis A cases in the past. And part of that may be because of some of these risk factors that I mentioned before that could predispose individuals to a more severe outcome of a hepatitis A infection. And so of the cases that have been reported and of those that we have been able to get risk factor information, 47% report some sort of drug use, 11% report men who have sex with men behavior, 7% report homelessness or unstable housing, and then, and actually I think if you hit enter again, 27% have a history of hepatitis C. And so, the two that are highlighted there as kind of the big or main risk factors for this particular outbreak. And in co-infections of hepatitis A and C, as we talked about before, in terms of chronic liver disease, can certainly result in more severe outcomes with an infection. So these are definitely groups that we're trying to focus on with some of our response efforts. Next slide. VDH launched its hepatitis A vaccination campaign in January 2019, and I will note that was before we declared our statewide outbreak status, because even at that time it was known that we had neighboring states with increased cases and outbreaks. And so the goal of the campaign was to try to get ahead of that and identify those high-risk groups throughout the state and integrate and try to get them vaccinated. And so we are looking to integrate hepatitis A vaccine into our routine health department clinic services, as well as educate the public on the importance of hepatitis A vaccination and prevention. VDH Central Office here in Richmond continues to coordinate with local health districts and work towards achieving its campaign goals and address hepatitis A investigation needs. Progress has been made with the campaign, and we've got a few slides that will highlight that. And Central Office will continue to work on addressing any challenges throughout this response, and we expect this work and the campaign to continue into 2020 until our reported hepatitis A cases return to baseline. And so just like we did a retrospective study analysis of our cases earlier this year, as we continue to hopefully see a decrease in hepatitis A cases into 2020, at some point we will continue to work with CDC to determine when we have moved through this outbreak and are no longer considered an outbreak state. For our central office response, we have pulled in the Division of Immunization, and primarily Marshall is the point of contact there, DSI, and we have a few folks, including myself, that kind of help support the coordination as well as the investigation of these cases, including our regional epidemiologists who are doing a fantastic job working with our districts. Occasionally, we may reach out to the Office of Environmental Health Services or the Office of Drinking Water, depending on what sort of events that kind of come up as we run into these cases. Because individually as they occur, like I mentioned before, they may be part of these high-risk situations that then require more coordination of other offices within VDH or even some of our local or state partners. And of course, most importantly, the local health districts, as well as the MRC volunteers that are volunteering and helping them with either the case investigations or the vaccination clinics or community outreach campaigns that we are trying to do in order to get ahead of or mitigate this particular outbreak. And I do think it says a lot when we have had 0 reported deaths due to hepatitis A infection for this statewide outbreak. For the number of cases that we have had, that is unusual compared to a number of other states within the U.S. And so I do think that speaks to a lot of the work that we've been doing, educating providers, educating the community, and trying to get the vaccinations out there to folks. So again, these are notes from Marshall, kind of expanding on some of the progress of the work coming out of the Division of Immunization. And I will say one other unique note at the very end, the last point there. We also did try to put out a Pandora radio ad, specifically targeting sort of the millennial population that we were seeing that may be associated with some of the high-risk groups. And we're also looking at trying to push out vaccines to any food handlers. I mean, anyone who wants a vaccine can get it, but we also continue to want to make sure that anyone who does handle food in a restaurant setting is also vaccinated, because I think that does mitigate a lot of potential work if and when we ever do have a case or these individuals exposed to cases. The next few slides kind of highlight the work regarding the adult hepatitis A vaccine. And you can see here from 2018 into the middle of the graph there, and then starting January 2019 is when we kind of began our hepatitis A vaccine campaign. And orange is the private sector, blue is the public sector. And in general, both of those have increased over time throughout this year, through the third quarter. And hopefully our quarter 4 2019 numbers will be as good, if not better, showing a continued increase. And so when we do take a look at 2019 as a whole, in terms of cumulative adult vaccinations that have been administered, we do see nothing but increase, which again is good and shows the great work that's being done at the local level. As I mentioned before, in terms of both the incubation period of the virus, but also the high-risk individuals in general, finding and connecting with these individuals can be quite challenging and certainly time-consuming. There's a lot of trying to work with them and trying to get them to open up to our EPIs and public health nurses in order to share this information, be willing to receive, PEP or the vaccine, especially if they're contacts and not cases. There are some things here that I think probably Marshall would be better to speak on in terms of eligibility for the vaccine and the logistics of getting the vaccine in the right area at the right time. And I mentioned food handlers a slide ago, and from CDC's perspective, they have not been as proactive with food handlers, but I think we're making that kind of a state priority or like secondary priority right behind those initially identified high-risk groups, because we definitely do not want to rule them out. And we've already had situations throughout the state where we've had food handlers that have been confirmed hepatitis A cases, and the amount of work that the health district has to go through in terms of notifying the public, manage the information and the messaging, as well as stand up some of our points of dispensing can certainly consume a lot of time and resources, which are always, for our health departments, always a challenge, even on a normal day. So, all right, so going from here, obviously we are going to continue to push our vaccination campaign, and we are going to continue to do that through 2020. I mean, this is quite an unprecedented year for reported hepatitis A cases in Virginia. And for Virginia, it is the highest year since 1990. So the number of cases so far this year have already been higher than some of our pre-vaccination era years for hepatitis A. And I think, again, this underscores the important work of public health and our volunteers that help, as well as the need to continue to support epidemiologic and disease prevention activities, and especially vaccinations. So with that, that concludes my presentation. And we do have some questions. Oh, and I did want to acknowledge Marshall, not only for the slides that he provided and help for preparing for today, but also because of all the work that he's doing, leading a lot of this coordination with the districts regarding the vaccination campaign. So he's been shouldering a lot of this and has been doing a remarkable job. We are going to send out the slides, and I did talk to Adrinia about including a lot of the links that I used to build the information that I presented, so you all will have that as a resource if you want to dive further into this topic. We had some questions from Brad, and I don't know if we'll have any others come in, but I'm going to take his questions in reverse order. So the first one was whether or not we've seen an increase in liver cancer as a result of this statewide outbreak. And the answer is no. I think for us, hepatitis A does not cause chronic liver disease, and so it is an acute infection that does resolve. I think if we were dealing more with a hepatitis B or hepatitis C outbreak that was much larger in scale, I think that would probably be more of a focus for us. But for this outbreak, because it's hepatitis A, I think our bigger focus is more on the individuals that have chronic liver disease or concurrent hepatitis B or C infections because of the severe potential for severe illness, specifically the acute liver failure. I think that's more of a concern and something that we're more in tune with for this particular outbreak, since liver cancer is not something that's associated with hepatitis A. Does the hepatitis A infection produce long-lasting immunity? The answer is yes. Both the infection of the virus and the vaccine both result in long-lasting immunity against the virus. Generally, we don't see reinfection unless there is a condition that the individual has that makes them immunocompromised in some way, shape, or form. But I will note, just because Brad asked that question, in terms of recovering from a hepatitis A infection, you can have a relapse within the 6 months of recovery. But generally, past that point, you do not have any kind of chronic illness that results from this, and generally the protection after that is long-lasting. The last question that he had was whether or not we've seen an increase in hepatitis A infections in regions with flooding and potentially that resulting in contaminated drinking water. So I will say, with our case investigations and outbreak investigations, because of hepatitis A being what it is, specifically a fecal-oral transmitted virus, if we do not rule out the possibility of contaminated water supplies, as well as looking at food sources, international travel, etc. Historically, we have not necessarily seen this as a major issue for regions that are more prone to flooding than others. It tends to be more of an issue when you have, say, like a septic system that's not well maintained, or a drinking, a water supply that is inadequately treated. And generally, a lot of that may fall to Office of Environmental Health Services or the Office of Drinking Water if we suspect that might be contributing to cases that we are seeing for a particular cluster. And in terms of, and I wasn't sure, Brad, if you were talking about just in general regarding the flooding and the drinking water, or if you were talking about this specific multi-state outbreak. But in regards to this specific multi-state outbreak, most of the cases are being epi-linked based on person-to-person transmission, direct person-to-person contact, through some of the methods that I mentioned up there before, the drug use, sexual contact, household contact, and or homelessness or unstable housing. And I am not aware of any specific situations that have involved potentially contaminated drinking water for this particular event. We've had some food handlers that have caused us to ramp up some local responses, but that's about it.
All right, are there any other questions? I am not able to see the chat box, so please send those questions to me by way of email. If you want those answered now, if you can send those to me, or you can send them when you think more about the presentation after I send the presentation out to everyone. Feel free to send your questions at that time, and I will make sure that Jonathan receives your questions and respond, and I will send the response back to you all. Are there any questions? Feel free to email me.
Thank you, everyone, for your time. And like Adrenia said, Marshall and I both would be happy to answer any questions that come out after this particular training. So.
All right. Okay, so if there are no questions, feel free to contact me if you do have any questions for later. I will make sure that I will send the presentation out to everyone that attend the session on tonight, but please make sure that you sign in with your coordinator if you're at the local health districts, or contact VA MRC at gmail.gov, and we will make sure that we verify you and train, and that way you can receive the presentation along with the additional resources that Jonathan will make available to all of us. Thank you all. There may be one question. Do you mind me checking real quick? Just give me a second before we log off. Okay, there is. Christina Morris has a question. Does resolve mean cure, a cure for the disease? Resolve.
Resolve just means that you recover from the infection. Yes.
Okay, that was asked twice.
Okay.
Brad has another question.
Brad.
No, he just said, hey, can you just respond by way of email to him the answers to the questions that he provided earlier?
Yeah.
Okay.
Can you forward that to me?
Mm-hmm. I definitely will. All right. Well, thank you all for joining tonight. Thank you for putting up with all of our always technology issues. I don't know why that is. But have a good evening and have a good holiday, and we'll see you all in the new year. Thank you all.